Good morning, ladies and gentlemen. I'm Dr. Hu Chaorong, the president of Taiwan Neurological Society. It's my great honor to be invited to join this summit, especially the more advanced molecular genetic for diagnosis of infectious disease. Our first speaker, Dr. Michael Robert Wilson. He is a graduate from University of California, San Francisco Medical School. And then he moved to the Harvard University to receive neurological residency training. Then he did his postdoctoral fellow training in National Emerging Infectious Disease Laboratory at Boston University School of Medicine and the University of San Francisco. Currently, he is the associate professor in residency of neurology, medical school of UCSF. Today, the topic of his talk is neurologic infections descend from Metagenomics and Transcriptomics. Let's welcome Dr. Wilson.
Thank you very much for having me again. It's a real pleasure to be back, and I look forward to the discussion. So I'll begin similar to last year, but then take some detours. There we go. And these are my disclosures to start. And just a couple of just quick background slides on encephalitis. So as was said in the introduction, I'm a neurologist, and we mostly do research, but I do see patients every week with unusual central nervous system inflammatory diseases, primarily cases of infectious and autoimmune encephalitis. And we know that about half of these cases, even with advanced testing today, go undiagnosed in the hospital, which is a real barrier to care. And it's particularly frustrating because we actually have many good treatments for different encephalitis etiologies, not just infectious, but also for the growing number of recognized autoimmune causes of encephalitis. But it's difficult to start those treatments when you don't have a firm diagnosis or even a category of disease that you think a particular patient has. And then on top of the increasing recognition that many causes of cases of encephalitis may be autoimmune. Of course, the reason we're here today is that we also recognize there's a huge variety of infectious causes of encephalitis, and that the landscape keeps changing from year to year. And so, the candidate-based diagnostics, where we, send off 1, 2, or 3 individual pathogen-specific tests to rule in or rule out a particular infection, are not really adequate to the task either of anticipating new infectious diseases, re-emerging infectious diseases, or even known infections that are either too rare to kind of have pathogen-specific tests kind of on hand at every hospital, or just to expect physicians, even specialist physicians, to kind of keep such an extensive differential diagnosis in mind for all the different clinical spectra that these patients can present with. And so I don't need to, belabor this for this audience, but metagenomics has a real multiple niches to fill for these difficult to diagnose neurologic patients. Can identify completely novel divergent pathogens not previously linked with a clinical phenotype, like Zika virus, unusual orthobunyavirus infections that we've identified in cases, there's that may have been recognized to cause systemic disease previously, but now are appreciated to have neuroinvasive potential. And then again, rare pathogens that are known to cause encephalitis, but just aren't commonly on the differential. And then I think we all hope that maybe with a combination of the sensitivity, specificity of metagenomics plus a host response analysis, maybe we can help rule out infection in those suspected autoimmune cases that we want to empirically immunosuppress. And so I'll start with the kind of final chapter on a study that we were in the middle of that I presented last year, which is kind of taking a more focused approach with a large population of HIV infected patients in Uganda. And these are all patients who, to varying degrees, had suspected tuberculosis meningitis. So we know TB is a huge problem worldwide, and that TB meningitis in particular is a very feared complication. And of course, there's a concern that these cases are going to rise in the wake of COVID-19, having kind of refocused so many public health resources. And so the best test currently, it's not the gold standard. Of course, the gold standard is culture, but the test that seems to have the most sensitivity specificity is a cartridge-based PCR test, the GeneXpert Ultra in CSF is thought to be 70% sensitive relative to the probable and definite TBM cases. And so definite TBM is a case that's been microbiologically confirmed in spinal fluid, and probable is a case in which it has not been confirmed, but there's high clinical suspicion, maybe because the patient has a basilar meningitis and is known to have systemic TB, but it hasn't been definitively shown to be in the central nervous system. And so, it's a question as to, what are those 30% of other patients? Is that because the PCR assay is insensitive, which is completely possible because TB is a paucibacillary infection, so very hard to detect? Or is it, especially in an HIV population, just that these patients, especially the probable cases, just don't have TB in the first place as the cause of their meningitis, and they have mimicking infection? Or is it some combination of the two? And that's a big problem because underdiagnosis, missing cases, will delay life-saving therapeutic interventions to treat TB meningitis, and overdiagnosis, treating patients for TB with only a clinical diagnosis of TBM will expose them to the side effects of those medications, induce premature diagnostic closure. And also, I'm learning as I learn more about the therapeutic trials in TB meningitis, where many possible and probable TBM cases are enrolled, really hampers the progress in the field in terms of developing and evaluating new therapeutics for TBM if a significant proportion of the patients in those trials aren't for sure, don't for sure actually have that disease. And so this is an ongoing collaboration with University of Minnesota and Infectious Diseases Institute at Makerere University in Uganda. And the goal there has been to do metagenomics to kind of solve this problem of kind of both detecting TB and alternate infections, but also leveraging the host transcriptomics, because we know that mNGS, just like PCR, is going to have some sensitivity issues for detecting TB and CSF. And so ultimately, this paper was recently published. We enrolled 368 patients and did RNA and DNA sequencing on CSF. And the upshot of the pathogen detection was that mNGS performed pretty well, so about 74% concordance with the definite TBM cases. Those are, again, patients who are PCR positive and or culture smear positive in CSF. But even in the definite TBM cases, there was one co-infection, an unrecognized toxoplasmosis case. And then in the probable TBM cases, we did detect TB and CSF in 3 of those that had been missed by conventional testing. But we also found a number of both treatable and highly mortal co or alternate infections in those cases, suggesting those patients really didn't have TBM. And then that was even more prominent in the possible / indeterminate TBM cases. Again, patients that still are frequently allowed to enter into TB meningitis therapeutic trials. And this is a list of kind of the range of viral, parasitic, in other infections that were identified in these cases, especially this is the the possible group. Again, you can see a wide variety of both treatable but also very serious neuroinvasive viral infections. And I'll highlight one, which is a Wesselsbron virus, which is a flavivirus, a cousin of yellow fever, that was detected in a man who we also found had TB meningitis, so another co-infection. And he presented with pulmonary TB and advanced TB, HIV, and had just initiated antiretroviral therapy and presented with encephalopathy, vomiting, weight loss, and cough. He had temporal wasting, and was so systemically unwell, had multi-organ failure, as well as meningitis. He had an acellular CSF reflecting his very immune compromised status, but again had relatively highly abundant detection of TB in the CSF, as well as very high levels of Wesselsbron virus that allowed us to reconstruct most of the virus genome. And you can see here that it clusters with other Wesselsbron strains that have been sequenced near Uganda. And there's been at least one previous case of encephalitis from a lab accident in South Africa, but it's not a widely recognized neuroinvasive virus there. These were additional, again, bacterial and parasitic cases that were identified in this cohort. And I'll just move to the transcriptomics piece, which was, we were excited that despite, like that patient I showed you, and many patients having relatively acellular CSF, we were able to get robust transcriptomic data for most of the samples. And then talented postdoc Akshay Ramesh generated a machine learning classifier with an initial set of 70 cases, 32 with TBM, 38 with other infections, to identify genes whose expression levels predicted TB versus not TB meningitis. And once she kind of came up with what a classifier that was optimized for sensitivity, she identified primarily 4 genes that were most predictive of a patient having TB meningitis. And we were happy that all 4 of these genes have a rich TB literature around them. They're all implicated in the host response to TB meningitis. And even this initial gene here, this guanylate binding protein 5, is part of an existing blood-based 3-gene classifier that distinguishes pulmonary TB from other infections. And we then kind of took that classifier and evaluated in a separate 130 patient test cohort, and found that in the blue dotted line here, that the classifier alone, so this is again not using any non-host data, just the host classifier alone was pretty accurate for discriminating between cases that were TB meningitis versus not. And then in a rules-based fashion, we would use the metagenomic hit, the bugs identified by metagenomics, to overrule the call by the host classifier. So if the host classifier called someone as TB meningitis, but the metagenomic assay identified an alternate infection, for instance, Neisseria meningitidis in a couple of cases, then that would overrule the call by the host classifier. So the host classifier was designed to not miss TB cases, and then metagenomic results were used to enhance the specificity of the combined classifier. And then a more recent addition to that study was led by a highly talented high school student who's now at UCLA, Rithwik Narendra. And he asked the question, typically we obtain 20 to 30 million sequences per sample on the research side. And, of course, that poses obstacles if you want to deploy a technology like this in a less resource-rich environment. And so he asked the question of how many reads did we really need to be able to get similar performance of the combined classifier with these samples. And so he did some in silico subsampling and looked at the loss of sensitivity for both detecting TB and non-TB pathogens in the cases that we sequenced, and then also looked at the performance of the host classifier at varying levels, varying sequencing depths. And to make a long story short, the consensus kind of combination set of sequences that he tested out on kind of all the cases in the data set was 100,000 paired end reads from the RNA-seq data set, as well as 500,000 paired end reads from the DNA-seq data set. So a total of 600,000 reads. Again, we knew we would miss TB detection at such a shallow sequencing depth, but the hope was that the host classifier would catch those cases and that we wouldn't miss too many of the non-TB pathogens. And so this is kind of the graph I already showed you before of kind of the overall performance of the assay with deeper sequencing. But then this is the performance of the same classifier using only, again, 600,000 total paired end reads. And again, there was very similar area under the curve and sensitivity specificity. So this suggests that in addition to increasing sensitivity for TB detection at a minimum, a combined host and pathogen detection assay may also allow for decreased sequencing depth and decreased cost of a combined assay. Now I want to shift gears and tell you about a case. So this was a patient that evaluated with Prashanth Ramachandran, who led the TB meningitis study with Akshaya, as well as with Mary Rolfs, a talented pediatric neurology resident. This is a right-handed man in his early 20s, so had a history of 20 episodes of recurrent neutrophilic meningitis, as well as a more recent episode that involved the brain. And he had a history of cold-induced asthma and seasonal allergies, and presented over and over again with headaches, fevers, photophobia, phonophobia, rigors, night sweats, and mucorigidity. And this kind of just details his workup over time. So he, in his first episode of meningitis a few years ago, he had a very inflammatory CSF profile, over 2,000 white cells, predominantly neutrophils, but like as was the case with every subsequent presentation, infectious disease testing on CSF, including one time having his CSF sent to UCSF for clinical metagenomics sequencing, was always negative. This first presentation came into the hospital, of course, was treated initially empirically with antibiotics for bacterial meningitis, but within 2 to 3 days, clinically was doing better and never looked toxic to begin with, and so was sent home quickly on oral antibiotics. Interestingly, the following week, his monozygotic twin brother also developed clinical syndrome worrisome for meningitis, but it was presumed to be viral meningitis and no LP was performed. But then 2 years later, he had another episode of meningitis, again with very inflammatory neutrophilic CSF, had a very short course of antibiotics before being discharged. And again, his infectious disease testing was negative. And again, he had a third episode, again, inflammatory spinal fluid, again, very brief course of antibiotics, and again went home. And then the fourth episode, 5th, 6th, 7th, 8th, 9th, and then just started to not even come into the hospital for these episodes. He had neuroimaging on certain occasions, which was always normal. But then he started to become more disoriented in these later episodes. And started to have seizures. And this was his MRI in one of those later presentations where you can see there's some T2 changes in the medial temporal lobes, as well as a T2 lesion in the pons. He also had leptomeningeal enhancement. And even 2 months after this episode, still had these abnormalities on MRI and still had cognitive deficits. At some point, people started to thought to give him steroids, and he had a very significant and rapid recovery. It was also noted on later on that he was having recurrent ulcers, both in the mouth and one occasion in the genitals. And so when we saw him, we thought, could this be a genetic syndrome, especially given his monozygotic twin brothers episode? And so we sent off a panel, and it turned out that this patient had a mutation in complement factor I, which is actually important for the inhibition of the complement cascade. And so patients with mutations in this inhibitory pathway can have overactivation of the complement cascade and present not just with neurologic sequelae, but with autoinflammatory sequelae systemically as well. There's a number of these autoinflammatory conditions that are now recognized. And this is a kind of an empiric treatment history for him. So after evaluating him, and learning about his genetic diagnosis, we trialed him first on anakinra and then canakinumab, IL-1 inhibitors. And since that time now, for essentially 2 years, he's been meningitis free on that medication. And what's interesting is, collaboration with Charles Chu, who will speak next. Charles kindly looked back at the metagenomic sample, the data set that was generated when his CSF was sent to look for infection a couple of years prior, and looked at the expression profile of this patient's CSF relative to patients with autoimmune encephalitis and patients with bacterial meningitis. And not surprisingly, given the neutrophilic predominance of the patient's CSF, pleocytosis, this patient looks a lot more like a bacterial meningitis case in terms of the host profile. And interestingly, there's some evidence there in the gene expression of upregulation of interleukin-1 pathways. So it fits both in terms of kind of how he presented, but also gives a clue as to what has turned out to be a really highly effective treatment for him as well. I want to just tell 2 additional quick stories, shifting gears once again to I think a study that we don't talk about enough, a really nice study that was led by Dr. Sanjuti Saha, who's a really talented microbiologist in Dhaka, Bangladesh, who came a few years ago to the BioHub with an incredible part of an incredible collection of spinal fluid that she's carefully built up over more than a decade or 2 decades, most closely now, of children with meningitis in Bangladesh. And in those over 20,000 cases, she had identified diagnoses in about 20% using the tools available to her at the hospital. So culture, pneumococcal antigen testing, and then PCR for common causes of childhood meningitis. But her trip to San Francisco was focused on, what could mNGS add to the diagnosis and so she brought 36 positive controls, 25 idiopathic cases, and then 30 negative controls to look at. And again, kind of is a similar theme to the TB story. mNGS was concordant with 70% of the known infectious cases. it was even more sensitive if you excluded the cases with high CT values suggesting low pathogen abundance. So we know that that's been shown over and over again that mNGS can be less sensitive than a optimized pathogen-specific PCR. So excluding those low abundance samples, it was 89% concordant. But then in the idiopathic cases, mNGS identified an infection in 40% of cases. And interestingly, and those are listed here, and interestingly, was a big surprise to Dr. Saha was that 3 of the cases had incredibly high levels of chikungunya virus in the CSF. What was interesting about that was that all those cases came from 2017, and there was a chikungunya virus outbreak in Bangladesh at the time. But the thought of her pediatrics colleagues was that that chikungunya virus was not typically neuroinvasive, and so there wasn't testing done on CSF to look for whether these children had chick meningitis or not. So Sanjuti set up a qPCR for chikungunya virus and tested all the CSF samples that she had banked at that time, and found an additional 17 for a total of 20 chikungunya virus meningitis cases that had presented. And you can see that they track perfectly with the outbreak of systemic cases in the hospital at the time. And this, again, here's a phylogenetic tree showing where those chikungunya virus strains cluster. And lastly, I'll end with a study that was published this past year by Mayo. I think I'm sure many of the talks in this conference are, for good reason, focusing on the wonders of metagenomics, but of course it's like any diagnostic test, there are cautionary tales, and so I think this study was important that just kind of highlight patient selection being a really important consideration when sending a test like this. So this was Mayo did a retrospective study of CSF samples that they sent for mNGS over a 2-year period. And overall, they had, from the Mayo cases, which had more clinical data with them, there were 9 positive cases out of 53. However, 6 were thought to likely be contaminants. And then from the outside Mayo cases, there were 3 out of 27 positives. But one of those thought likely to be a contaminant and was also not a true positive. It was because it was below the reporting threshold, but was noted as a result in the test. And I think what's just want to highlight here is that many of these cases, almost half of the Mayo cases, had no CSF pleocytosis, and most of those patients were immune competent. So these were not like the Wesselsbron TB case that I presented earlier. Most of those cases had normal proteins and normal glucose, and most of the time the test was being sent to rule out an infection, not because an infection was highly suspected in these cases. The other thing was that the vast majority of the cases had CSF sent from a later lumbar puncture, not from the initial spinal tap done in the emergency department. And indeed, 5 out of the 6 false positive Mayo cases had essentially bland CSF. And so I think that, again, just highlights an important lesson that in immune competent patients, bland CSF is not likely to be infectious, not likely to come from someone with infectious meningitis in the first place. And so any diagnostic test for an infectious disease, whether it's mNGS or a herpes PCR, et cetera, is going to have a higher risk of false positives in a sample like that. I think it also highlights that because it's a direct detection technology, that outside patients who are presenting with a chronic meningitis, mNGS is more likely to pick up a pathogen early in the course of disease. And so even if people aren't sending an mNGS, on day one of hospital admission, saving a frozen aliquot of that CSF sample so that it can be sent later if necessary, I think is a very useful, rather than sending spinal fluid from a tap done two weeks later, maybe after the virus has come and gone. Subthreshold results, have to be interpreted with caution, and the one gratifying thing was there were no false negative results again in this study. So again, highlighting the potential, especially combined with host response of mNGS helping rule out infections in patients who are suspected to have autoimmune or other non-infectious causes of meningitis and encephalitis. And so with that, I will end and just, highlighted a number of highly collaborative studies, and just want to thank Charles, thank folks in my lab that I highlighted along the way, as well as Dr. Saha, our collaborators in Minnesota and Uganda and at the BioHub, and our funders. So thank you.
Thank you, Dr. Wilson, for your excellent talk. Dr. Wilson mentioned about his research about TB meningitis, autoinflammatory syndrome, and the pediatric meningitis in Bangladesh, and also male CSF study. All of them are very impressed. So Dr. Wilson's talk is open for discussion. Any question or comment? Okay, thank you. Well, we will discuss your talk later in the panel discussion. Thank you.
Thank you, Professor Wilson, for your nice talk.